Back, everyone. Today, we're taking up a really crucial topic for both your daily clinical practice and your NEET PG preparation. We're going to conceptually master irritable bowel syndrome, or IBS. So let's just dive straight into this explainer and make sure your basic fundas are absolutely clear.
We've got a very logical flow today. We'll start with the basics and systemic associations, move through the clinical presentation and the Rome 4 criteria, unpack the pathophysiology, and finally look at diet, lifestyle, and targeted medical management.
All right, section 1, let's look at the introduction and associations. What actually is IBS, and honestly, what is it not?
If you look at standard handwritten notes, IBS is fundamentally defined as a functional bowel disorder. It's essentially the GI system's reaction to stress. Conceptually speaking, you absolutely must remember there is zero anatomical pathology here. None. If you do an endoscopy or colonoscopy, the mucosa is going to look completely normal. There are no ulcers, no tumors, no structural abnormalities at all. It's simply the gastrointestinal tract overreacting to physical or psychological stress. That is a massive takeaway for your exams. Is that concept clear? Now make a quick mental note of these systemic associations. We're looking at things like lactose intolerance, celiac disease, fibromyalgia, chronic fatigue, and generalized anxiety disorder. Why am I pointing this out? Because in your MCQ clinical vignettes, examiners love to describe a patient with abdominal pain who also has severe muscle aches or anxiety. Fibromyalgia and anxiety are classic high-yield clues pointing right to IBS. Moving into section 2, let's talk about the clinical presentation and the Rome IV criteria. Basically, how is this patient actually going to present when they walk into your OPD? Picture this classic demographic in your mind. You're usually looking at a young female patient under 45 years old. And what's her main complaint? Crampy, lower abdominal pain. And here is the real functional hallmark of the disease. The pain is episodic, maybe once a week. It gets aggravated by stress or a heavy meal, but it is reliably relieved the moment she passes stool. She might also complain of bloating, belching, nausea, but that crampy pain getting relieved by defecation, that's your diagnostic bullseye right there. Okay, listen carefully because this is a guaranteed MCQ. You absolutely have to memorize the Rome 4 criteria to officially diagnose IBS. The rule is recurrent abdominal pain, minimum 1 episode per week for at least 3 months, and that pain must be associated with 2 or more of these 3 features: a change in stool frequency, a change in stool form or appearance, or the pain is related to defecation. Do not forget that strict 3-month timeline. Examiners will definitely try to trick you on that. Along with the pain, the patient will definitely have altered bowel habits. That's actually the most consistent symptom. We classify them into types. D positive is diarrhea predominant, which is usually small volume with mucus. C positive is constipation predominant. But note this down right now. The M positive, or mixed type, where prolonged constipation is suddenly interrupted by episodic diarrhea, is actually the most common clinical presentation in practice. If they ask for the most common type, go with mixed. Now pay very close attention because these are your red flags. These are features against an IBS diagnosis. If your clinical vignette mentions nocturnal diarrhea, meaning the patient is waking up from a deep sleep just to pass stool, or if there's steatorrhea, blood in the stool, fever, unintentional weight loss, anemia, or a raised ESR, rule out IBS straight away. IBS does not wake you up at night, and it definitely doesn't cause rectal bleeding or weight loss. If you see those, you need to be thinking about organic diseases like IBD or a malignancy. Let's shift to section 3, pathophysiology and visceral hypersensitivity. We really need to unpack the underlying mechanism to understand why this functional pain is happening. The central pillar of IBS physiopathophysiology is this brilliant concept of visceral hypersensitivity. This is exactly why the patient feels such severe cramping. Let's deconstruct this step by step, just like we do in the classroom. Step 1, minimal rectal distension occurs. We're talking about a normal, everyday amount of gas. Step 2, this tiny distension inappropriately fires up the pain receptors because they are highly sensitized. Step 3, this stimulation causes increased colonic motor potentials, basically those painful spasms. And step 4, it shoots straight up to cause central activation of the cingulate cortex in the brain. The gut is just hyperreactive. Normal physiological stretching is being interpreted as severe pain by the central nervous system. You can see it perfectly illustrated in this graph. Look at the wide gap. The blue line is our IBS patients, and see how it shoots up so early? They are reporting high levels of pain at very low distending volumes, like 20 to 60 milliliters. Meanwhile, the healthy controls don't feel pain until the volume is much, much higher. It's a clear-cut demonstration of rectal hypersensitivity.
Now, for the rank-deciding questions in your entrance exams, you need to know the biochemical mediators behind this hypersensitivity. There are two main culprits: an increase in serotonin-containing enterochromaffin cells in the gut lining and the activation of vanilloid channels, specifically TRPV1. Memorize those two molecular details. They are absolute gold for tough MCQs.
Moving to Section 4, Diet and Lifestyle Modifications. When a patient comes in, we always start with conservative measures. It's actually really impressive. About 70% of IBS cases show massive improvement with just basic first-line interventions. What are they? Simple physical activity, like telling the patient to walk 6,000 to 8,000 steps a day, and dietary modification, specifically a reduced FODMAP diet. Let me say that again. Mark my words. A reduced FODMAP diet is your absolute first line of attack. Examiners love asking for the full form of FODMAPs, so know it by heart. It stands for fermentable oligo, di, monosaccharides, and polyols. These are basically poorly absorbed, highly fermentable, short-chain carbohydrates. You need to counsel your patients to cut down on things like apples, mangoes, wheat, honey, legumes, and cauliflower. These are notorious triggers for IBS flares, so keep them in mind. Let's look at the simple physics and chemistry happening here. When these poorly absorbed FODMAPs travel down and hit the large intestine, the local gut bacteria go crazy and aggressively ferment them. This produces a huge amount of gas. Simultaneously, because these sugars are osmotically active, they pull excess water right into the bowel. So the trapped gas gives you that classic bloating and distension, and the excess water causes the diarrhea. It makes perfect sense, right? All right, Section 5, Pharmacological Medical Management. What do we do for the 30% of patients who just don't improve with lifestyle changes? We escalate. As you can see in this algorithm, our pharmacological strategy is strictly bifurcated. We treat diarrhea-predominant or D-positive IBS completely differently from constipation-predominant or C-positive IBS. It is highly targeted based on the presentation. This table is a goldmine for your MCQs, so memorize these choices. For the D-positive diarrheal patients, we give loperamide to slow down gut motility. We also give antispasmodics, but strictly 30 minutes before food to prevent the cramps from even starting. Sometimes we'll add antidepressants to modulate that gut-brain pain axis. Now, on the flip side, for C-positive constipation patients, we start simple with stool-bulking agents like psyllium husk or PEG. If that fails, we bring out the advanced secret to GOGs, luproprostone, which is a chloride channel activator, linaclotide, a guanyl cyclase agonist, or tenapanor, a sodium-hydrogen exchange blocker. Make sure you know their mechanisms of action. Lastly, just a quick note. Things like antibiotics and probiotics don't have a determined role in standard guidelines right now, so we don't routinely rely on them. But examiners absolutely love to ask retrospective questions about obsolete drugs. For example, allocetrone, a 5-HT3 antagonist, was actually pulled from routine use because it caused severe ischemic colitis. Eloxetiline caused pancreatitis, and tegaserod caused cardiac toxicity. You will probably never prescribe them, but you definitely need to know their fatal side effects to score well on the exam. To wrap up this explainer, I want to leave you with a quick clinical thought exercise. Imagine your long-term classic IBS patient suddenly walks into your OPD complaining of new-onset nocturnal diarrhea and unintentional weight loss. What is your immediate next clinical step? Remember those red flags we talked about earlier? How does this completely shift your diagnostic algorithm? Think about it. Recognizing when a functional disorder might actually be hiding a serious organic disease is exactly what makes you an exceptional doctor. Thanks for tuning in, study hard, and I'll catch you in the next one.